On screen, you can see the case study I've been given for my examination. What I'm going to do now is take you through my initial thoughts and the information I would take from this document we've been given. So pain 1, it's been described as a gradual onset, and for the nature of the 2 to 3 year description, we would highlight this as a chronic condition. Pain 2, described as pins and needles. This could suggest a neurological influence resulting from pain 1. Further evidence of them being linked would be further down in the body chart section. We can see that as pain 1 increases, pain 2 increases as well. The client cannot recall any incident of injury, which poses questions surrounding a degenerative condition, which could fall in line with the individual being 51 years of age and getting to that point of life where things like osteoarthritis are becoming more common. Linking to the client's past medical history, we can see that he has had osteoarthritis in both knees and the left hip. We must be aware of the osteoarthritis within the client's history, as this could have continued effects on the back pain that they're experiencing. The client is also pending knee replacement surgery. However, his surgeon has said he needs to reduce 5 kgs first. This information could suggest that the client is at risk of being overweight or is overweight. Having no cauda equina symptoms rules out the major severity of this condition, which would fall in line with the client's opinion of the severity being moderate. Obviously, if we do have cauda equina symptoms, we would take this as an emergency and refer them on. Noting the easing factors the client has expanded on of lying down, i.e. rest, and heat to the area, and also the aggravating factors of getting up from a chair, so after periods of sitting, and a rotation mechanism for the pain 2. Noting these factors will help sort of help the rationale behind what your clinical impression would be and the treatments, the objective assessments and the treatments you may give. So they are my initial thoughts on the case study. From here, we're going to go into the assessments I would do to help back up my rationale. So moving on to the observation and sort of the assessment and treatment sort of stages. My potential diagnosis straight away would be either a lumbar disc degeneration or spondylosis. This is due to the dull pain experienced by the client being caused by the degeneration of the discs in the lumbar spine. The potential of the client being overweight would provide further rationale for spondylosis, as the excess load places more pressure on the joints, and that accelerates the wear and tear. The pins and needles experienced are due to the osteophytes, or extra bone growths that affects the surrounding nerves and then lead to those pins and needles. Okay, so the first observation sort of assessment you would do is you'd look anteriorly, laterally and posteriorly at your client and sort of identify any sort of major problems that you need to worry about during treatment. So anteriorly, first looking on, I'm looking at symmetry of posture. So I'm looking, are his head, neck, shoulders all in line, rather than sort of having that sort of head to the right, shoulders to the left, and we're having a curvature in the spine. So looking anteriorly first, I'm looking for that symmetry of posture. So head's in line, neck's in line, shoulders in line. Perfect. If that's happy days, we move on. Alignment now, so I'm looking at your ASIS. So the ASIS is here. We're looking at, are they level? Yeah, that's absolutely fine. Again, we move on. Muscle bulk is the third thing we look for anteriorly. So muscle bulk, we could have really developed right side, or we could have a really undeveloped left side. What we're trying to do is just measure out whether they are level, whether they, if they're not level, would they have an effect on our client's history of present condition. So again, we're looking sort of the pecs area, the traps, the shoulders, looking level. Yeah. So once you're happy anteriorly, you're looking at those three things are the main sort of factors for anteriorly. Once you're happy with that, we're going to move on to laterally. So we're going to get your top client to turn to his side. And here, what we're looking for again is symmetry of posture, sort of the pelvis, is there any tilting going on? So they're the two sort of things we're looking for here. So symmetry of posture, we've got normal lordosis, with Hay et al. 2015, explaining approximately 43 degrees is your normal lordosis. So what we're looking for here is that normal 43 degrees and then back out. In this situation, we could see something called kyphosis, otherwise known as sort of hunchback. This hunchback puts more weight and pressure through your lumbar facet joints and can create more problems. So those are sorts of the two things we're looking out for. So lordosis is normal, 43 degrees, and then kyphosis is hunchback position, and that will be a problem because we're putting more weight through. From laterally also, we're looking at the pelvis tilt. So anterior tilt is where sort of your PSIS is massively up compared to your ASIS. This again puts more compression through the lumbar facet joints, creating more problems. On the opposite side, posterior tilt would be this way. Just move this way a little bit. So move your hips and keep yourself there. That's it. So posterior tilt is where your hip flexors are overactive, which increases the pressure on the anterior aspect of the lumbar spine. So again, those are the four things we're looking for laterally. If those things are okay, or if they're not, we write them down and we sort of treat differently in different aspects. Finally, we're moving on to posterior. Okay, so again, you get your chance to move round. Once they're moved round, again, we're looking at similar things. So we're looking at symmetry of posture, alignment, bruising and swelling. Those sorts of things are sort of constant throughout your assessments, but especially when we're looking posteriorly, symmetry of posture is quite important. So commonly, you'll see scoliosis from your clients. This scoliosis is a curvature in the spine. Often you'll see sort of a lean to one side, sort of the abs anteriorly, you would have seen sort of lopsided almost, and posteriorly you would definitely see it. Okay, this scoliosis can be caused through an increased muscle bulk. So there comes the importance of looking at the muscle bulk. So we're looking at the lats areas and looking down here as well. So what we're trying to see is if one side's overdeveloped or if one side's underdeveloped. Again, these are conditions we just need to note. And then following on to our treatment stage, we just have to make adjustments for that. Again, so alignment here, what we're looking for to help with that identification of scoliosis if it's not prominent, we're looking at alignment. So shoulders level, we're looking at the bottom of the scapula, inferior angles level. Okay, from there we're looking at the PSIS, which is here, perfect. You then look at the crease of the gluteals. So here, are they level? Yeah. And then finally, we could look at the back of the knees, the posterior side of the knee. Is the crease there level as well? Yes. Again, those are the alignment things we look for, and just to sort of work out whether we've got any underlying conditions that could be affecting this back problem. Finally, we're looking for sort of any bruising or swelling. In this case, we've got a chronic condition, so bruising and swelling may not be related to our problem. However, in an acute stage, for example, we may see some bruising, swelling that may affect the client's posture, the way they're standing, for example. So yeah, those are the sorts of things we'd be looking for during our observations, anteriorly, laterally, and posteriorly. The next step of our assessment would be to sort of look at the leg length discrepancies, the range of motion tests with sort of overpressures, and then any specialist tests that we could do to sort of rule out any neurological issues, and also look at maybe diagnosing sciatica. So the first one we're going to look at is the leg length discrepancy test. So what I'm going to get my client to do is lie back down, all the way down. I'll see he's going to relax his arms. I'm going to pick the feet up at the ankles. What I'm going to do is get them to be neutral and just see if there's any difference in the heights of any bony points. So as you can see here, there is the left leg has a higher internal bony point here than the right, and you can see it recreates on the outside with the left also being higher than the right. Once we look at that, we'd move up to our sort of patellas. So again, we're going to get them to come down, look at the patellas. Again, the left is higher. So this client would suggest he has a leg length discrepancy with the left being shorter than the right. Again, these things are things to note. So for my clients, specifically to the case study, I would be looking at if they don't have any leg discrepancies, the problem's not going to be coming from sort of leaning, posture issues. It's going to be coming from a different sort of problem. Okay, so the next test I'd be doing is looking at range of motion. So what I'm going to get my client to do is sit up and just stand up off the bed for me. Just move this out of the way. Perfect. So the back has sort of, the lumbar spine especially has sort of three movements we can do. So we've got flexion, extension, and then side flexion to either side. So what I'm going to get my client to do is he's going to come this way for me here. So I'm going to get him to go flexion to start with. So what I want you to do is just put your hands in front of you, and we're going to come down as far as we can. Client's got a really good range of motion here, so we record that sort of distance. In terms of applying overpressure, what I'm going to do here is get the client, stabilise the lumbar spine, and just apply an overpressure to my client. If it's a soft end feel, we've got no problems. If there's a sort of a stiff end feel, that's when we sort of start looking deeper into the issue. So he comes up from his flex position. This time we're going to get you to do extension. So what I want you to do is I want you to get your hands on your hips, sort of in like this, around your ASIS, and then I'm going to get you to go flex as far back as you can without falling over. All right? Okay, again, applying overpressure on extension is a little bit difficult, but we've got to, again, stabilise the lumbar spine and just apply that overpressure. Okay, and when we bring our client back up, turn him facewards towards you. The final ones are side flexion. So side flexion is sort of keeping our hands on our sides. We're just working it down in sort of a parallel motion. So again, what I'm going to get my client to do is work to the right first. So what I'm going to do is keep your hand on here for me, and I want you to work all the way down the side of your leg, as far as you can go. About there? And then we're going to again apply the overpressure, stabilise here, and we're going to apply that overpressure. Right, we come back up. So, and the same again on the left. Again, stabilise and provide the overpressure. Perfect. Right, the next test we're going to do is called Babinski's test. Babinski's test sort of highlights any neurological issues. It's a sort of feeling test on the plantar fascia of the foot. What we're expecting for a negative test is the big toe to flex in as I perform the movement. If the big toe sort of extends, that's when we've got a positive Babinski's and we've got a neurological issue. So what I'm getting my client to do is get him to lie on his back on the bed again for me. Sorry, one sec, let's move this up just so they can see. If you could take your socks off for me, sir. So what I'm going to do is I'm going to take my pen, start on the lateral aspect of the foot, and we're going to run it all the way over, and then as we come up, we're going to roll inside onto the medial side. So what we're expecting is a flexed toe. Right, here. Perfect, there's that flexed toe. And on the right. And then we see it. Perfect. So this client would have a negative Babinski's test, especially when working with a client with pins and needles experienced. It's important to rule out whether that's serious neurological issues or whether we can diagnose that as sciatica. So with this negative result here, we're going to move on to the single leg raise, which is a sciatica test. Okay, so moving on to this one, what we're going to do is we're going to get a straight leg raise, and the symptoms can normally occur between 30 and 70 degrees. This is sort of a tingling, burning sensation through like the back of the hamstrings, sort of the back of the knee, calves and the feet. Anything past 70 degrees, that's probably just tight hamstrings, with range of motion for them about 80 to 90 degrees. So once we're going to do that, we're going to bring the leg up from about 30 degrees and keep going to 70. Tingling felt? Yeah, tingling felt. So again, the client's expressing that tingling sensation down the back of his leg. Equally, to enhance this test and to really check if we are working with sciatica here, what we can do is we can get the client to bring his chin to his chest as we perform the movement. So this time I'm going to bring the leg up to about 25 degrees, get the client to bring his chin to chest. No, keep that and bring your chin to chest there, and then go through that again. Feeling that tingling sensation? Yeah? Perfect. So that's a symptom of sciatica. This test would say we've got positive sciatica, which would mean our treatment would be able to do joint mobilizations and central PA. Moving on to the treatment stage of our video. What we're going to do now is centralized PA. This sort of joint mobilization is very much in the name posterior to anterior movements. So I'm coming in from the posterior and I'm moving anteriorly. So that's why it's called PA. Especially with a chronic condition, we're looking at sort of the higher levels of joint mobilizations. So we're looking at 3 on 4, where we're just trying to stimulate the movement that causes this issue, and we're trying to do that repeated movement, the joint mobilization, to get that sort of used to it and build its back up into it. So what we're going to do first of all is we're going to locate the top of the lumbar spine. What I'm going to do then is I'm going to work down one by one, and I'm going to ask the client whether that's pressure I'm putting on or whether that's the symptom that they feel when they are just in general life. Okay, so what I'm going to do first is I'm going to get the heel of my hand, come in there, the other hand just on top. I'm on L1 here, so what I'm going to do now is just going to put some pressure in. Going to speculate, going to ask the client whether it's the pressure I'm putting or that's just the symptom. If it's the pressure, we move down a level. So we go now on L2. We're looking again. Again, it's the pressure, so we go down to L3. Pressure, L4, say, and that's where the pain starts to come on. That's where the symptom they feel is exactly the same as when they're in normal life. Once we find this is where we go for our joint mobilizations. I'm personally going to go for a grade 3. So I'm going to go down to 50% of the range. I'm then going to do large oscillations, moving on to the end range. So that's going to be my treatment. I'm going to do 3 blocks of 1 minute. What I'm going to do for the sake of the video is just do 2 sets. So what we're going to do is we're going to start and we're going to do the large oscillations on L4 starting from now. It's important to keep in contact with your client. If they start feeling sort of burning sensations, anything sort of pins and needles wise, that's when we've probably got to stop. If they are just feeling the pain they normally feel, that's okay. It should subsidise with the more treatment they receive. How's it feeling?
Yeah.
You okay? Again, keeping to our time schedule is quite important. We don't want to be overusing the joint, and we don't want to be keeping that problem there. So that's time there. What we'll do is we'll let the client have a little rest, maybe say 15 seconds, and then what we're going to do is go straight back into our second treatment. So back onto 2, 3, L4, and again, we then begin our treatment. Grade 3 joint mobilizations again, so we're going down into the deep range, and then we're providing those large oscillations. Joint mobilizations have been sort of known to reduce stiffness, reduce pain, and also increase range of motion. This client especially says we have trouble sort of getting up from seated positions and after being stuck for a long time, so this should help freeing up that movement so it's not just a constant problem for them. So that's time. We will go through the third treatment just for the sake of the video. So again, 15 seconds off, and then we go to our final treatment. Again, really important we work out where our L4 is, make sure we're still working the same group, and then we begin. Keeping that pressure posterior to anteriorly is really important. We don't want to be sort of moving the muscle group sort of proximally or distally. We want to be keeping the pressure sort of posteriorly to anteriorly. And that's time. So I selected my treatment based upon the sort of symptoms my client was displaying. So we got that dull pain in the lower back, and then the sciatica, if it was. I presume we sort of highlighted sciatica as the symptom, so we moved into joint mobilizations and central PA. That is my examination video.